35-year-old female with closed distal and both bone fracture of the right forearm. We've done rush nail for the fibula and ulna and plating for the radius, sir.
Good morning. Yes, sir. What plating is this?
Ellis plate, anatomical plate.
It's a locked plate.
Locked
It is not a buttress plate.
Yes, sir.
Yeah. Yes, sir. Go ahead.
So these are the intraoptics, sir. There was a coronal split of the distal radius. So we reduced this and we applied a vehicle.
Go to the pre-op. Can you zoom the image, please? Because our images are very small images, radial, what is called digital X-ray itself are miniature images. See, there is intraarticular extension.
No, sir.
But there is a comminuted fracture.
It's a comminuted distal radius.
So there is ulnar variance positive, negative?
Neutral, slightly positive, sir.
Slightly positive. Positive, no slight pregnancy.
Positive,
No pregnancy. Okay.
Positive.
So you have gone with the, how many hold plate?
4-hold.
4 hold.
5
So
hold.
5 hold. You have achieved the buttressing or anatomical reduction?
Anatomical reduction.
Anatomical. Yes. Go back. What is this? Same case?
Rush nail, sir. We put rush nail for the...
Rush nail from where? From above, below?
From proximal to distal.
Entry point is from the olecranon.
Olecranon.
Below the tip of the olecranon.
Yes, sir.
Yeah.
Talwakar nail, sir.
Talwakar nail.
Talwakar nail.
Why KJ?
Sir? Yes, sir.
What is the principle of Talwakar nail? James Rizal, what is the principle of Talwakar nail? You have got Talwakar nail, rush nail, square nail. KJ also is there. What is the principle? Ulnar nail, yeah.
The tip of the nail has got a bevel and it is not like a trocar tip. And there is a small dent just below the bevel. This is to negotiate the curve of the radius smoothly. If it is a straight nail with a trocar tip, it penetrates the cortex in a curved form. So this will easily the smooth surface of the bevel and it is blunt. It will not allow it to penetrate readily. So it prevents penetration to the cortex and tries to negotiate the cortex beyond the
Radius.
convex border. It has to face the convex border of the radius.
Shall I add one more?
Of the Talwakar nail designed for radius.
Yes, sir.
Yes.
Whereas ulna it is a regular square nail with a trocar.
Yes.
So can I add one more point? So it is a comminuted distal and radius with the distal third fracture of the ulna. So the nail is better or plate is better? Biomechanically. By all practical purposes, the both bones forearm should be treated as
Intraarticular fracture.
intra-articular fractures. So is it holding principle better or in a somewhat it is not matching or not
Plating
matching?
is better.
Huh? Better is plating. Why? Why better plating?
Rigid fixation, anatomical reduction, and
Rigid fixation. Oh, you are giving rigid fixation.
stable
fixation.
fixation.
Stable fixation, biomechanical stable, and you are achieving the good anatomical reduction.
What is that radio density seen on the post-op X-ray on the dorsal cortex? What is that? It's a fragment that is displaced.
Okay, one more point.
Indications of ORIF.
Severe comminution was present, sir.
More so with very wide and large abrasion. The source for infection.
No, sir, because of the abrasions, we put rush nail, talwakar nail for the ulnar.
That's what I said. Because you are gone for the nail, that is a more chance. Because your entry point is below the tip of the olecranon. Because you are very near to the injury side.
And the entry point also there is a abrasion.
Ah,
So there is a high chance of growth of infection.
adi point.
That we can conservative. Ulnar fracture. Initially a slab. It is not a badly displaced fracture.
Yes, sir.
So you might have taken simple.
So when you open up a comminuted fracture, all the fragments are likely to become loose and irascible.
It is a bag of bone.
Especially in presence of an abrasion or a wound. Crisscross K-wise would have been better than the plating. Plating is a risky proposition.
That's what I said. By all practical purposes, the fracture, both bones, forearm, should be treated as intra-articular fracture.
Yes, sir.
They demand biomechanics, they demand anatomical reduction, stable construct.
No.
There is a very sharp fragment
Yes, sir.
exactly anterior with the course of the fracture.
Okay, this is very, very important. Not so your life is not for 1 year, 3 years. It is for 35, 40 years of practice. Practice make man perfect.
Yes, sir.
You don't know why you are taking care?
For additional stability.
Huh?
Additional stability.
Additional stability or
There's
the radial
combination.
stylet also is there?
Radial style.
Radial stylet also is there?
Fragment there are no screws.
No, we put one screw.
So there is radial stylet or no stylet? You are there for surgery? Yeah.
The vehicle, we put vehicle for the, we reduced the coronal fracture and we had to put vehicle for that, sir. For it to hold.
Next case. 64-year-old female with closed lateral malleolar fracture of left ankle. It's Lag-Hansen classification, supination, external rotation type. We have done ORIF with plating for left fibula.
Go back. Pre-up.
So 75-year-old male with intertrochanteric fracture of left femur, Boyden-Griffith type 2. This is unstable type. We have done CRF with long PFN for right femur with washer.
What is the purpose of washers? What is advantage or disadvantage? Go back, first one. Go back to the first one, pre-op. 75 years female. What is the type? 2, Boyden-Griffith. With comminution, without comminution?
With combinations.
Stable or unstable?
Unstable.
Okay, next. What is the purpose of washers? Is a good or bad? Advantage, disadvantage?
Prevents medialization of
Prevents?
medialization.
What medialization?
Medial migration of
Prevents the migration
Migration.
of screw into
And
the
buttressing
joint.
effect
Yes.
also.
One, inka. Better stable construct. It never allows to go in. See the distance of inka. Easy removal also. It can help in easy removal also. Okay. Better construct. It gives you the better construct and prevents the proximal migration. What is Z effect and reverse Z effect? What is Z effect and what is a reverse Z effect? Which is good and what is the phenomenon?
both are bad, sir.
Huh?
Both are bad, sir.
Both are bad. Yes, next. Abhiram.
So the defect is inward migration of the proximal
Huh?
screw and outward migration of the distal.
Indeed.
Z effect.
Clear and loud. I want you can give this mic. Yeah. Z effect.
Z effect, sir. Z effect is medial migration of the proximal screw and outward
Next.
migration of
Next. Next. Srikanth. Z effect.
Medial migration of proximal screw.
Next. Z effect means lateralization of the distal screw, that is 8 mm screw. Proximally one is 6.4 mm. So lateralization of the distal screw is called as Z effect. Lateralization of the proximal screw is called as a reverse Z effect. The cause for reverse Z effect is bad. The reverse Z effect is seen in improper reduction, improper fixation. Z effect is good, both are not bad. తెలిస్తే తెలుసు అని చెప్పాలి, తెలియకపోతే ఐ డోంట్ నో అనాలి. తప్పులు చెప్తే 0 మార్కులు కాదు, మైనస్ మార్కులు పడతాయి, ఉన్న మార్కులు కట్ అవుతాయి. నెక్స్ట్
7-year-old female with spastic diplegic cerebral palsy with adductor contractures, GMFCS 4. Son.
వాట్ ఈస్ ద ఫుల్ ఫామ్? GMFCS.
Gross motor functional classification scale.
Classification score. Yeah.
Score.
Classification system. Okay. What do you mean by type 4? Go back. What do you mean by type 4? The patient is independent, non-independent, taking
patient is dependent, cannot mobilize independently with the help of aid.
He can be ambulatory or not.
Can be transported only with the help of a wheelchair.
Wheelchair transported with the help of. What is type 5?
Type 5 is no upper body trunk control also, sir. So the patient has to be
Which state
strapped
the patient is bedridden, totally bedridden?
Type 5.
Type 5. So it is very near to type 5.
Yes, sir.
So it is a severe grade. Yes, go ahead.
So there is also subluxation, spastic subluxation of both the hips as a result of the diplegic cerebral palsy, sir. Right subluxation.
What about knees? Knees are good.
Yes, sir.
What about foot?
There is a cavavarus deformity of the foot also.
Huh?
Cavavarus deformity. Planovalgus.
Clinical picture? Clinical. 6 points are very, very important for anywhere, whether the local presentation, state, or international presentation. First one is clinical. Second one is pre-op. Third one is peroperative. Fourth one is post-operative. Fifth one is follow-up. And sixth one is videos. A clinical photography X-ray video. What are the different?
In the hips there is, sir? He is unable to. With us,
He is a wheelchair born. It's a wheelchair born. Achapali. This a patient is a wheelchair born. Wheelchair born and Devani.
He has to
What
be
do you mean by wheelchair born? And wheelchair born and wheelchair born?
She has to be transported in a wheelchair. Patient has to be transported in a wheelchair.
And Devani, he needs support. And
Assistance.
he needs support. He can able to sit. That's important.
So you've done adductor tenotomy bilaterally, and we've done obturator neurectomy followed by skeletal traction for 3 weeks. The anterior division of the obturator nerve was severed. Ends was crushed to prevent neuroma.
So selective obturator neurectomy has
Yes,
been
sir.
done.
Yes, sir.
So on table is relaxation is done.
Yes, sir.
Before surgery, you have examined the patient
Yes,
under
sir.
anesthesia.
Yes, sir.
So
There was severe.
whatever the spastic contractures are getting relieved of or persisting.
No, sir.
No.
No.
So after surgery?
After surgery, it has been relieved.
Good. So the surgery is under spinal or general?
General, sir.
General. Okay. So what is your follow-up? How long you want to follow up the child?
Till skeletal maturity.
Till skeletal maturity. How do you follow up? 1, 2, 3, 4. You can tell me 1, 2, 3, 4 stages of post-op care. What is the age of the child?
7 years. Sir.
7 years. That means she needs the care, total care by the parents.
Yes, sir.
Yeah. So how do you follow? 1, 2, 3, 4. First 3 months, what do you want to do? Second 3 months, 1 year, 2 years, 5 years. Is the child is fit to go for a school?
She can be transported in a wheelchair with
Okay.
assistance.
So how do you assess? How do you assess? So what is the final prime goals of management of CP? Patients should
We
be
have to-
socially, economically, independently stable. You should accommodate into the society. Otherwise, you are not a surgeon. ఈజ్ నాట్ ఎ పేషెంట్.
Yes, sir.
రాముడే భీమ, ఎవరికి వారి యమునా తీరి. నెక్స్ట్ కేసు. అది ప్రిన్సిపల్స్ అన్ని ఫాలో చేయాలి. ఊరికి సర్జరీ చేసి పంపించామంటే వీళ్ళ పెడితే వీలవుద్ది.
Biden and Griffin type 3, sir. Subtracondral extension is there, sir. These are the CM pics, sir.
పిక్చర్స్ క్లారిటీ రావట్లేదు సార్, కొద్దిగా పిక్చర్స్ ఇంప్రూవ్ చేయాలి సార్ ప్లీజ్.
We have done CRI with long PFN, sir.
ఓకే, నో వాషర్స్.
No, sir.
So 40-year female with 1.5 years old post-op right hemiarthroplasty, now presented with a periprosthetic fracture. This is Vancouver C3.
So below the stem.
Yeah, below the distal to the stem, unstable fracture.
Unstable.
We've done
No,
open
process. No, go back. Is the process is stable? Bone stock is good. Stable processes. Bone stock is good. Only this is Vancouver type 3.
Yes, sir.
Distal to the stem. Yes. Plan of management.
Done ORIF with plating.
What plate? DCP or LCP?
Locking compression plate.
Locking LCP. Yes. What is the cause of stress riser? C3 Vancouver. What is the cause? Is the fall or injury or twist? Huh?
Fall while walking. Slip and fall while walking.
Where in the house?
In the house.
From the where? From the staircase or in the plain ground?
On the
While going to the bathroom? Huh?
She was walking on level ground and she slipped and
So trivial, not severe.
trivial.
Yes, go ahead.
29-year-old male with 7 years 7 months old closed supracondylar fracture of left femur with implant in situ. We have done implant removal.
How many years old?
7 years.
7 years, very good. So per operate you got any problem?
Adhesions.
Adhesions, blood
No
loss?
problem.
Blood
No
loss?
blood loss.
Is the patient has gone the knee stiffness? No knee stiffness.
Yes, sir. Knee stiffness is.
Knee stiffness
Flexion
for the
of-
last 7 years.
Yes, sir.
So what is
Flexion
ROM at the time of surgery or implant removal?
At the time of surgery, the flexion was nearly 70 degrees, it seems, sir.
Uh-huh.
Now, while he presented to the OP, the flexion was 20 degrees, sir. That.
7-0.
Yes, sir.
So after surgery?
After surgery, it was 90 max, sir.
So still you have to follow the
Yes,
case.
sir.
Yes.
Yes, sir. Manipulated. After manipulation, we got 80 degrees of flexion, sir.
Though another inko part cheptaru. So it is already 7 years old. What's the age of the patient?
29 years.
Young chap. Go back. Before. Yeah. So the young how many screws? 1, 2, 3, 4. Ikkada enni unnai? 4 or 5?
5 units.
5. So the problem of supracondylar fracture is there is one problem. Even though after 7 years old, 7 months old, 7 years, 7 months old, lateral LCP are removed. The problem is after treatment protocol. Problem is there are high chance of refractures and regaining of joint stiffness or fracture disease is very high. The problem with the femur is the muscle power is more than the bone power. So there is high chance of fatigue fractures. That is one point. You should be very careful even after removal of the plate. You have to follow the case minimum of 2 years. Why? Go back after removal. Removal. See, there is a good amount of remodeling. No, there is not a good amount of remodeling. This pattern is different. Even after 7 years. That is a problem of the femur. So you should be very careful. Yes, sir, go ahead.
36-year-old male with 13 months old post-op distal and radius fracture with implant in situ. We have done implant removal.
Is there ulnar variance? No variance? Go back. If you don't know, you have to say don't know. Kathal cheppakudadu. No stories are accepted. This is
Morning, sir.
scientific
These are the
podium.
cases done in Unit 2. The 68-year-old male with intertrochanteric fracture of left femur. This is Borden Griffin type 3. We have done ORIF with the plating and long PFN for left femurs.
So recon locking plate. So what is the purpose of recon locking plate in this case?
Hold butters.
Butters. So you said it's already communicated. That's what. It is not only given the fracture stability, not only anatomic reduction, fracture stability, to prevent ద రివర్స్ జెడ్ ఎఫెక్ట్ అది కూడా ఉంటుంది. లేకుంటే ఇంప్రాపర్ రిడక్షన్, ఇంప్రాపర్ ఫిక్సేషన్, హార్డ్వేర్ ఫెయిల్యూర్, పూర్ ఫంక్షనల్ రిజల్ట్స్. నెక్స్ట్
50 years old female with compound grade 3A right medial epicondyle avulsion fracture of right humerus, sir. She has wound in the anterior aspect of arm, sir. We have done ORIF with KVS and with anterior transposition of ulnar nerve. There's a 18 years old male with closed medial epicondyle fracture, avulsion fracture of left humerus, sir. For this, we have done ORIF with KVS fixation with anterior transposition of ulnar nerve.
So go back. This is important, sir. This is the school of thought. Some people are using 2 kVs, some people are using the screw, because medial epicondyle flexors are more powerful than the extensor. That is the school of thought. Your kVs will act like a biological fixation. They cannot give the stable construct, because with the ROM,
Yes, sir.
joint reaction forces, there are high chance of backout effect. Nowadays, you are getting the threaded kVs also. Yes, sir, what is your opinion? So, big enough, yeah.
KVS.
Very small. It is a big fragment. One of the important point in radiology, when you're talking in relation to digital radiographs, what you are seeing radiologically is different per operative. It's a bigger fragment. It is not a smaller fragment. That you have to analyze. Okay, sir. This point should be taken. No other way. Yeah, that is a point important. So,
50 years old female with closed medial malleus avulsion fracture of left leg.
okay, go back. One point. This is the point. So, the medial condyle fracture will go for malunion. The lateral condyle fracture will go for
Non-union.
non-union. Why?
Vascular could.
Poor vascular. Right side, malunion. Why?
Vascular bond.
More vascularity. Okay, right.
We have
Children, not in adults.
we have done ORIF with tension band wiring for medial malleus.
Comminuted fracture. Suppose it comminuted. Yes. Comminuted fracture, high chance. Yes. Comminuted fractures more common in adults or children? Adults. Very good.
Good morning, sir. These are the cases done in Unit 3. 34-year-old female with closed bimalleolar fracture of right ankle. It is pronation external rotation type of injury.
Pronation.
Yes, sir.
What type of injury is?
Pronation and external rotation.
Pronation, external rotation. Oh. Supination, external rotation. Transverse fracture is it. Supination, external rotation injury. Transverse fracture of the medial malleus indicate that it is a supination, external rotation injury.
Fibular fracture is higher in and
Masonry fracture comes under pronation external rotation injury, where there is partial disruption of the syndesmosis. In Masonry, there is partial disruption of the syndesmosis, whereas in Dupuytren's fracture dislocation, there is complete disruption of the syndesmosis. That is the main difference. But both are pronation external rotation injury, not supination external. Yes.
we have done open reduction internal fixation with tension band wiring for medial malleolus and plating for lateral malleolus. 75-year-old female with intertrochanteric fracture of left femur, sir. This is Boyded Griffith type 2. We have done closed reduction and fixation with PFN for left. It was a comminuted fracture, sir. 75-year-old female with 3 months old intertrochanteric fracture of left femur. We have done closed reduction and fixation with long PFNs. Is a 27-year-old male with closed proximal third, middle third junction shaft fracture of right femur. We have done closed reduction and fixation with ILN.
So you have done one case, वो female patient को PFN करे, set हो गया, all is well, very good. So shortening, everything has been corrected, very good.
Good morning, sir. This is a journal club for today. This is a comparison between radial head replacement and open reduction internal fixation in unstable multifragmented radial head fractures. The study was conducted at the Edouard Herriot Hospital and Clinique du Parc in Lyon, France.
No. ఇక్కడ చెప్పేటప్పుడు లెవెల్ ఆఫ్ స్టడీ కూడా మెన్షన్ చేయాలి.
It's a retrospective single center study.
Yeah, retrospective study. అది important. These 3 points are very
Yes,
important. So what is the advantage of prospective and retrospective? Which is better study?
Prospect.
Then why you have selected retrospective study? With intention, without intention, just for presentation?
Yes, sir. We wanted to assess the comparison.
Already
between
assessed.
these two.
Retrospective is already assessed. Already results are given. Already study done. Results are given. So you want to give any clear message? No message? No message. Just presenting going. Huh?
No, sir.
So what is your conclusion? What is your take-home message? What is your criticism? For the last proceed.
Yes, sir. So the radial head fractures constitute about 17 to 19% of elbow trauma and 33% of elbow fractures. Mason type 3 or unstable and comminuted fractures are very challenging to treat. So traditional radial head resection will, might lead to instability, arthritis and other complications. So the two main options present are ORIF and radial head replacement. Study objectives to compare clinical outcomes of radial head replacement versus ORIF and to assess elbow function, complication rates and overall outcomes. This is a retrospective study conducted from 2004 to 2007. 45 patients with Mason 3 unstable comminuted radial head fractures were taken, randomized into ORIF versus replacement groups, followed up for a mean of 8 years and evaluated with Broberg and Mori score and complications. Inclusion criteria were Mason 3 radial fractures, ulnar collateral ligament injuries, coronoid process fracture, proximal ulnar fractures, interosseous ligament injuries, posterior cubital articulation dislocation. Exclusion criteria was Mason 1 and 2 radial head fractures, old radial head and pediatric radial head fractures, and patients with poor compliance. So surgical techniques used were for replacement, monopolar titanium prosthesis, right medical technology implants were used. For ORIF, AO mini plates, K-wires, lag screws and T-plates were used. For both groups, the Cocker approach was done and ligament repair if required. Ulnar radial collateral ligament, annular ligament. So Broberg and Mori score has 4 components. One is pain, motion, stability and function. All these are, when added, give up to 100% points, 100 points. So the interpretation of this is 95 to 100 is excellent, 80 to 94 is good, 60 to 79 is fair, and less than 60 is poor.
So pain, motion, stability,
Function, yes, sir.
Which one has got highest points?
Motion, ROM. It is more important. It is more important. It helps in performing daily activities. Yes, sir.
Also you have to talk about dominant versus non-dominant.
Yes, sir.
High demanding, low demanding.
Yes, sir. So the results, functional outcomes. The replacement had 91% good or excellent results, while ORIF had 65.2% good results. So the mean Broberg and Mori score for replacement was 92.1 plus or minus 6, and for ORIF it was 72.4 plus or minus 7.1. So and the difference was statistically significant. So p-value was less than 0.01. When it comes to complications, the replacement group had 13.6% complications with 2 ROM deficits more than 30 degrees and 1 processus stiffness, probably due to overloading of the processes. And ORIF group had 47.9% complications, which included non-union, fixation failure, stiffness, heterotropic ossification. And here also the difference was statistically significant.
So there is a more complication.
In ORIF groups.
47.9.
Yes, sir.
Almost 50%.
Yes, sir.
That is, what is the ROI? More than 30 degrees.
There were 2 ROM deficits.
The complication rate is 13.6%.
Yes, sir. Yes.
So it's more in
ORIF group.
the plating.
Yes, sir. Discussion. The radial head plays a key role in elbow stability and force transmission. ORIF often fails in unstable comminuted fractures. Replacement provides better outcomes with fewer complications. However, the concerns are prosthesis loosening, wear, and long-term durability. So indications must be carefully selected. Unstable Mason type 3 fractures with ligament injuries should be there. Conclusion, the radial head replacement is better than ORIF in unstable comminuted fractures with better functional outcomes and fewer complications. The prosthesis problems remain for which long-term studies are needed. So the replacement should be preferred in Mason type 3 unstable fractures. Criticism, the study is limited to a single center in France and there is no assessment of long-term prosthesis survival or wear. Functional outcomes are limited only to Broberg and Mori score. And a high complication rate in ORIF group may also reflect level of surgical expertise of the surgeon. It's there in the... Yes, sir. Yes, sir.
Some of the journals are coming with the video clips also. WAO journals వస్తున్నాయి. WAO journals also there. Orthopedics. So they are adding the video clips also for better communication, better knowledge. Where is our madam? Pranati? Pranati trauma? Can shoulder joint has got a mechanical axis, no axis? Is there not there? Japan sir, you not sir? Huh? Yes or no? Yes or no?
Then sir, mechanical axis of?
Mechanical axis for shoulder joint, present or absent?
Right, sir.
Yes, is there, is there. Is the study. That is the study. My thesis work. నేను అదే అడిగింది
బయోమెకానిక్స్ హారిక
అందుకేనమ్మా నీకు కూడా చెప్పాలి ఆయన సెమినారు ఇది థీసిస్ గుడ్ మార్నింగ్ మహాలక్ష్మి ఏం బర్త్డేనా లుకింగ్ బ్రైట్ ఏంటిది
ఏం లేదు ఈరోజు స్పోర్ట్స్ ఇనాగరేషన్ ఉందంట సార్ ఇక్కడ స్పోర్ట్స్ ఇనాగరేషన్ ఉందంట మన దగ్గర కాలేజ్ దగ్గర సో వాళ్ళకి ఇచ్చింది సార్ అంటే అలా పెట్టారు వాళ్ళు చేశారంట వాళ్ళు
ఒలింపిక్స్